a small talk about new lifestyle during and after COVID-19. And I am currently as a member of the Japan National Task Force in Tokyo, and we work mainly on cluster intervention methods. And so we try to identify different clusters, and then we try to get common features and how we can constrain this epidemic. And today I'm going to tell you mainly about why this disease is a bit difficult to control and what we know about it and how we can overcome this at least for a while and to wait until better times. So next slide, please. So as I said, today I'm going to tell first about the novel coronavirus, and then I will overview a bit the main concept of Japanese program, which we coined as a 3C, and how we can identify the 3C, which means like crowded places, closed spaces, and close conversations. And then whether we can adopt this 3C concept and how we can adopt this in our lifestyle. And at the end, I will overview what we actually do not know about the current COVID-19 pandemic and why we currently require a bit more than probably it's necessary for its control. And next slide, please. So first of all, novel coronavirus 2019 is a disease that is caused by a severe acute respiratory disease. And usually the time from infection to the first symptoms is about 5 days, but it can be between 2 and 14 days. And sometimes it starts with fever and dry cough, but often also it starts first with some very mild symptoms like running nose or diarrhea. So as you can see, it's very difficult to distinguish this disease from common cold, for example. And that's why it's difficult to say whether you have this disease or actually it's a common cold. And in minority of people, we have a severe outcome. It means that after usually 7 days after the illness onset, this person may be admitted to the hospital. And unfortunately, maybe after 2 weeks, this person may admit to the intensive care unit admission. Next slide. But what is more difficult in this case is that about 1/2 of all cases are actually pre-symptomatic transmission. So it means that even if the person doesn't have any symptoms, this person can transmit disease and would not realize that this infection is so dangerous. And it was known that usually the person can transmit, for example, 3, 2, or 1 day before the symptom onset. So even before they're realizing that he or she has the symptoms. And usually the peak of infectiousness happens 1 day or at the day of illness onset. And also about 1/3 of people, or maybe 20% are asymptomatic. So these people would not even realize that they have the disease, but still they would be infectious to the others. And it was known that the severity affects all age groups. And usually the elderly people, the one we care more, it's more vulnerable and more susceptible to the disease. But very often, as you can see from this picture, that the person, maybe younger one, who does not have the symptoms, may bring the disease to the household and then put this elderly to the risk. And next slide, please. And in order to avoid this situation, what we want to know is about, okay, how we can deal with the disease and how we can restrict the transmission. And what we would start is usually to look on transmission routes of the disease. And it was identified that there are 3 main modes of transmission. The one mode of transmission is aerosol transmission. So it's when the person coughs or sneezes, then the cloud of particles emits. And it was known that this cloud of particles, it may consist of large particles, the ones that are quite large and they probably would fall down on the ground because of the gravity. But also it may consist of smaller particles, which would be very, very tiny, but they would be kept in the air for a long time. And the third mode of transmission is through contaminated surfaces. It's when these large particles would fall down on the ground, and maybe for some short time, I think that these surfaces can be contaminated. And the surgical mask can prevent some of these events. For example, for large particles, the surgical mask is very effective. And that's why wearing the surgical mask might prevent the transmission. And next slide, please. And from this perspective, you can see that if you have the main route of transmission as by large particles, which would fall probably like 2 meters away or 1 meter away from the person, then the social distancing that was advertised is very effective. And wearing masks is very effective. But if you have smaller particles, then you cannot restrict the transmission by wearing the mask, and most probably the outdoor activity or ventilation would be restricted for this mode. But sometimes we have contaminated surfaces, and in this case, you might have the disinfection of surfaces. And depending on this modes of transmission, you can see that we may apply different methods, but currently you may also realize that the government imply every particular restrictive measure, because actually we don't know much about which one is a mode, and it looks like it's a mixture of the three that drives the transmission of the disease. Next slide, please. And from this, as I said, on the figure on the top, you can see that the person who coughs, and sometimes it may happen during the illness onset, this person may drop the droplets quite near, but if it's small droplets, then there's much higher risk of transmission on longer distances. And next slide, please. And what we discovered from our work in Tokyo about the clusters in Japan is that a lot of people, about 80%, actually do not have secondary transmission. But there are some particular cases when we have clusters, and because of these clusters, there could be some particular secondary transmission in households, for example, to elderly people, to our parents. But these events, when we have a lot of secondary transmission, what we discover is that they're usually associated with some special conditions. And if you, for example, list all these clusters that you identify, then you will see that there are many common features between them. And for example, on this plot, you can see that approximately 80%, they didn't have any secondary transmission. But there was the cluster, for example, on a houseboat in Tokyo, where people celebrated New Year, and it was a closed environment with poor ventilation. And this index here probably caused around 9 secondary infections. And also we had some outbreaks in fitness centers. And in that case, also even more than 10 people were associated with this. And next slide, please. Right. And as a summary of this, you can see that when you try to aggregate all the data, in that case, what you would identify is that usually the transmission happens in closed spaces with poor ventilation and crowded places, or in close contact settings. By close contact settings, I mean that people may talk very close to each other or whisper on the air to each other, and in that case, there is a higher risk of transmission. And if you want actually to prevent the transmission in the community, and if you want to get a smaller number of cases, you may assume that from this picture that maybe if you avoid these clusters like in a houseboat or gym centers, then maybe you restrict and you would control the disease better. So the main aim of the program currently adopting in Japan, and I think in other countries, is actually to restrict these cases and to try to lower the risk of having clusters in the community. And next slide. And this 3C, usually what we found that it's connected to the loud cheering or singing or exercise. And you can see that it can be a concert or live houses, or it can be sport. But you can also see that in all these cases, sometimes the main people who participate are younger ones. And that's why there is a higher risk that this younger one would bring the infection to the households. And next slide, please. And accordingly, what we saw that there are many clusters originated in pubs and karaoke bars, in live music events or nightclubs, but also in the gyms, as I said. And very often this index cases are traced to symptomatic or very mild cases, and not to severe cases. And after that, we usually have the wave of severe cases associated with these clusters. And what interestingly, we didn't find the clusters that were traced to the public transportation, for example, to trains. And this may indicate that actually the aerosol transmission may take place, but it's not as a dominant mode of transmission. And this resulted, next slide, please. And next slide, please. Thank you. And what this resulted is that currently in Japan, we recommend the following measures to restrict the transmission in these clusters. And as you can see, what we arrived is that we need to ventilate the spaces and also to wear the mask and frequently wash their hands. And also try to sanitize the facility equipment. If, for example, it's a shop. And next slide, please. And also to limit the chances of person-to-person contact. And I think you all see these measures in Indonesia, and they were already implemented. But you can see also that we have much uncertainty about the main modes, and that's why we implement different measures that would lower the total risk. And maybe in the future, next slide, please. Maybe in the future we would arrive to this kind of situation, but I want to ensure that most probably it's temporary because there is much uncertainty about the transmission modes and about the disease because it's a novel disease and may lead to severe outcomes in some patients. And next slide, please. And this is because here what I listed, there is a lot of uncertainty. And as I said, there is we don't know exactly the infection fatality rate, for example, of disease. And as I explained before, we don't know the exact route of transmission, the dominant one, because maybe it can be by big droplets or by aerosol. Or also, we don't know why we see a lot of diverse spectrum in clinical outcomes. Some people, they have diarrhea, some people, they have smell of loss. And also the severity can be quite different for different people. But unfortunately, there is no efficient treatment at the moment, and there is no vaccine. And once they arrive, then these measures probably would be more weakened. And also we don't know, unfortunately, the exact length of the immunity or the length of the infectiousness, but we know that some disease, some transmission happened before the illness onset. Unfortunately, you can see that there is not so many known things, but what I want to say, and from my simulation, and from my study is that many people, when the cluster originated, it can be younger people or children who would bring the infection to the household. And this should not be stigmatized because the disease is very similar to common cold or to influenza. So it's very difficult to distinguish between this common cold and actually COVID-19. But because of that, we need to adopt the common measures, and actually there should be some kind of cooperation between different generations. And for example, children should bring some precaution measures, and also parents should bring some precaution measures. And once we cooperate and once we adopt some rules, I hope that we can control the disease, and this would affect the future. And then with more treatment and more vaccine, we will be able more efficiently to control the spread of the disease. And that's what I wanted to say with my presentation. So thank you very much for your attention. And next slide. And if you have any questions, I will be happy to respond. And on the last slide, I just showed the map of Japan and the map of Indonesia. And from the map, actually, what you can see that the most affected areas right now is around capitals. For example, in Indonesia, it's around Jakarta, and in Japan, it's around Tokyo. But also in Japan, for example, Hokkaido was affected because all these regions are well connected to the external world and also the kind of hubs for all people living in this country. And that's why what we see at the moment is the effect on these regions. And thank you very much for your attention, and any questions are welcome.
I'm here to talk on the elderly care in the physical distancing era and the lessons learned in Malaysia. My presentation today will cover the COVID-19 situation in Malaysia, and I will be talking about the background of long-term care and how aged care is operated in Malaysia. Following that, I will talk on the COVID-19 event timeline and how the aged care industry has responded to the situation. A little bit on the way forward for key stakeholders, and at the end of my presentation, I will summarize the highlights and some key take-home messages for the audience. The COVID-19 situation in Malaysia began on the 25th of January with the first confirmed case. It was an imported case involving 3 tourists in China who came into Malaysia via Johor. Then we hear that on the 31st of January, the World Health Organization already declared COVID-19 as a global health emergency. And by 4th of February, we had our first Malaysian case, the 9th case overall. involving a 41-year-old male who had attended a conference in Singapore and had a physical contact with the participants, but he was later discharged. The first local transmission was from a female detected on the 6th of February. And by the 11th of February, the Malaysia government had formed a special working committee on COVID-19. It was a joint committee between Malaysia and Singapore and headed by the deputy health ministers from both countries. A very momentous event that happened on the 27th of February, which involved Tabligh religious followers, I think about 16,000 of them, became the largest COVID-19 cluster in Malaysia. And this cluster has generated various subclusters and infected a lot of Malaysians. Yeah? The first sporadic case in which the disease has been found in the community was detected on the 12th of March. And the first case that was detected in the east of Malaysia was found on the 13th of March and involving a pastor, a 60-year-old pastor from Sarawak. And he was the first one who perished from the disease of the first patient with COVID-19 to die in Malaysia. The COVID-19 situation in Malaysia is monitored by the Crisis Preparedness and Response Center, the CPRC, which was established under the 9th Malaysia Plan. And as of now, we can see that Malaysia has a total infected of 7,619. The total recovery is almost 80% of 6,083 people recovered. The current active cases stands at 1,421, and we have experienced 115 total deaths so far. What is important is that from the slide, you can see that the COVID-19 incidence rate in Malaysia by age group, if we divide by age group, the two major groups infected are those in the age groups of 55 to 59 and 60 to 64. While the number of COVID-19 positive cases can be found among the millennials and also the group of people aged between 56 to 59. Yeah? So these are the two high-risk groups that is being attended currently. When we are talking about deaths from the COVID-19 virus, majority of deaths happened among the older persons aged between 60 to 79 years. This represents 53%, and majority are males in comparison to females. Now I will be talking about the context of aged care in Malaysia. A little bit of a background in care in Malaysia. A view of the landscape of long-term care in Malaysia can be seen from two axes. The horizontal axis represents the level of care provided by the services and facilities, from services and facilities providing care, low-level care for independent healthy adults to the most dependent older adults. And on the vertical axis, we have it represents where these services and facilities can be obtained, either from home, the community, or in institutions. So in the first quadrant here, you can see that these services are for are mainly residential and provided for older persons with requiring no or very low level of care. So we have the public, the blue ones are in public, public services or public funded facilities, which are called Rumah Sri Kenangan. We have 10 here in Peninsular Malaysia, 2 in Sarawak and 3 in Sabah. And besides that, we also have other state Islamic homes, similar to pesantrens that you have in Indonesia. We call them pondok, where older persons study religious texts and Islamic teachings. We also have Rumah Sejahtera or Pondok Sejahtera. These are provided by the non-governmental organizations, and also the old folks home. Some are provided by the not-for-profit, and while others are provided by the for-profit operators. Approximately 370 of them, which should be covered under Act 506. Yeah. We also have other charity and welfare shelters, including madrasah. These are regulated under the state or religious bodies. Yeah. For the dependent elderly who lives mainly in residential facilities, we have Rumah Ehsan. These are the home for chronically ill older persons. We only have 2 in Malaysia. And we have hospice services provided by the non-governmental organizations. We have a number of nursing homes. 26 of them are licensed under the Ministry of Health under Act 586. And we have public and also private hospitals, yeah, for short-term acute care. Then we, on the lower quadrant, we have services, non-residential services involving senior citizen clubs, activity centers, associations, yeah, and neighborhood groups. Yeah. The federal government also gives financial assistance program to older persons. Currently, about 500,000 older persons, yeah, are covered under this scheme. The Ministry of the Department of Social Welfare also provide home help program, which are run by through collaborations with non-governmental organizations. Usia Mas, some of these organizations provide home help services, mainly to cater for seniors who are living at home but needing some form of help. Yeah? And the last quadrant here is for non-residential services for dependent elderly, but these are mainly paid services. We have public and private clinics, physiotherapy, rehabilitation and dialysis center, mobile care, home nursing, and care at home services. And some families rely on domestic help or maid to care for their elderly parents. Okay, what can be said about this landscape is that the care in Malaysia is fragmented, with the public services catering for independent and community-based due to the deinstitutionalization, yeah? Because we try to move away from institutionalizing the elderly and hoping that more services will be provided within the community. Among the private service sector, yeah, they are providing for the higher level of care, nursing care, 24 round-the-clock nursing care, and for the chronically ill and dependent older person. But most of these services require families to be able to afford, yeah, to purchase these services. And the long-term care situation in Malaysia places a huge burden on families because not all of these services are available in their local area, and also in terms of affordability of the services required by families to take care of their aging parents.
Sorry, Dr. Rahima, I think we have about maybe 2 more minutes.
All right, okay.
Thank you.
Okay, the COVID timeline and aged care response in Malaysia started on the 24th of January. And from that, we moved in March, we have the workplace guidelines and infection control on March 16. During the first phase of movement control order, the aged care, the Association for Residential Aged Care Operators in Malaysia have provided leadership and coordination. And by March 21st, key experts in Malaysia have worked on interim guidelines and some relief efforts for aged care operators. And the important or momentous event is right at the phase 4 of the movement control order, which happened from 29th to April to 3rd May, where the COVID-19 testing of aged care centers was implemented. And because of that, the residential care clusters in Klang and Petaling Jaya, which had infected 36 people and involved 5 deaths, has been terminated. And on May 8th until now, sanitization of care centers are underway, and testing is still ongoing in the aged care centers. So total screening, currently 279 aged care centers have been screened, involving 11,000 residents, carers and staff, and 20% of this from those who are screened did not show any symptoms. Sorry, 87% did not show any symptoms. So the way forward for key stakeholders is to rethink their operations and business in order to continue in the new normal and to be able to sustain their operations in the new realities that you are facing now. Also, in terms of infection control training to be deployed to the aged care staff, and regarding the supply of protective equipment, and we need implementation plan on how to do this, how to do the infection control and how to supply the protective equipment for aged care to continue their operations. And having said that, the aged care industry needs to rethink their way of doing business, and we need to get reliable data for informed decision making. The key highlights and take-home message from my presentation is that in Malaysia, we are seeing increasing multi-sectoral responses to older persons' issues and challenges. Older persons are now categorized as a high-risk group. And we need to understand the impact of social distancing measures on older persons and the care operators and the staff. Malaysia has provided economic stimulus package for businesses and assistance and funding for care centers, but we need to. This is an opportune moment to align regulatory, industry, and residents' need. We saw the role of AgeCope in providing leadership and coordination during this pandemic, and we need other industry peak bodies to step in. Many stakeholders has provided guidelines, FAQ, SOPs, infographics for care operators, and we need to translate knowledge and action into actions and practice quickly. There are repeated nationwide screening of residents, caregivers, and staff of aged care centers. They are working on the SOPs for daycare and activity centers for the elderly, because we need to think of how to operate in the new normal as COVID-19 is going to stay for a very long time. So we need to see how we can resume our daily routines in the new normal. So that's all from me. Thank you very much. I will be happy to take on any questions later.
My sharing is basically very much looking at coming from the foundation. And as quite a lot of you would know, the foundation actually runs, we run various programs, but amongst one of the things that we do is really running a suite of community-based services, for older person. And so the spectrum of older person that whom we covered really ranges from the independent, the physically independent older person to people who are at the end of their lives, end of life care. So we do cover quite a wide profile of older people in the community-based care services that we run. And so my sharing today really focuses on that, focuses really from the ground, the impact of this pandemic. How is it affecting two levels really? One level is how is it impacting the service, the people who deliver the services, the professionals, the care workers who deliver the services in the midst of this pandemic, this situation. And of course, the other impact is really on the clients whom we serve, the clients, the older person themselves, the family members. What are some of the impact? What are we starting to see, on the ground? Because I believe this impact is still evolving. So this is going to be my presentation. Can I have the next slide? Okay, it's just some dates and significant milestones, so to speak, in the Singapore's management of the pandemic. We have our first case on the 4th of January, an imported case. And by the 7th of February, we've gone into DORSCON Orange. It is a risk identification level, which I will explain later what DORSCON Orange means. So we went into some starting implementing measures, for, safe measures, within the community, within the workplace. So on the 7th of February, we started DORSCON Orange. And by 5th April, we already seeing widespread community transmission, right? Where we get more and more cases. I think as all of you know now, Singapore has now one of the highest, if not the highest number of cases in Southeast Asia. So on the 5th of April, the government implemented what is known as a circuit breaker, popularly known as CB, which I'll explain what it means. And come 2nd of June, which is next week really, we would be coming out of the circuit breaker. The government already said that we are going to stop the circuit breaker. And so we're going to move into post the circuit breaker phase 1. And the government has listed 3 different phases of how we are gradually going to move back into so-called the new normality. Okay, so these are just some important dates for us to kind of indicate, at all these various points, different things were done. Yeah. So can I have the next slide, please? So this slide explains what DORSCON Orange means. And if you look at it, DORSCON stands for Disease Outbreak Response System Condition. Singapore started this, started drafting this and creating this DORSCON alert levels after our SARS experience 17 years ago. So you can see there are 4 different levels, and orange is kind of more than, it's quite high actually, it's just before red. So when orange kicks in, basically it means that we recognize that the disease is severe, it can spread easily, but not that widely yet. And that is already starting to have moderate disruption because quarantine has kicked in, temperature screening is done, there are visitors restrictions at the hospital, for instance, and for the members of public, we already need to be more alerted, like for instance, if you have a cold, you'll be given 5 days MC, regardless of how severe your cold is, or even if you have a cough, you will be given 5 days MC, for example, and the constant reminders of maintaining personal hygiene and that. So that was DORSCON Orange. So what happens to our cluster of services when DORSCON Orange kicked in? Can I have the next slide? So when DORSCON Orange kicked in, as you can see, these are all the services that we run in our suite of community-based services. For our primary care clinic, we run primary care clinics that take care of people 40 and above. So that clinic covers a very wide range of people in middle age, it's only 40 years old, but also the older, the more frail elders in their 80s, 90s. Yeah, so it covers a very wide range of individuals. For that clinic, it remains open. Now, first of all, before even that, we started split team. That means basically the entire foundation had the workforce split into Team A and Team B. And we go on a rotational basis back to the office. So for instance, Team A, for the first week, Team A might start going back to working from the office 135. And then Team B will then work from home on Tuesday and Thursday. And the following week, we will rotate, right? So Team B will come to office on 135, and Team B will start, will stay at, Team A will stay at home from Tuesday and Thursday. So we had that split team when DORSCON Orange kicked in. But as for our services, the primary care services remain open, but the focus is really on seeing patients with more acute problems and those with high risk. So the physicians will have to identify who are these people, because our primary care clinic is by appointment only. It's not a walk-in clinic where anybody can come because they're sick. So we have that. For our daycare, it remains open, but because of the split team, we started bringing in a smaller number of elders each day to the center. Initially, the center, could take in, like, say, 30 people, and when the DORSCON Orange kicked in, the number of elders coming to the center became smaller, half the size, about 15 or 16. Yeah, and priorities are given to high-risk elders. And for the other elders who are not coming into the center, we will provide constant monitoring over the phone and make home visits on a selected basis. And it's the same for our community care management services. They remain open as per normal, but the team were told not to just do phone call visits for what we call maintenance cases. Maintenance cases are clients who are relatively stable. They are not at risk, not so much at risk. Their condition has already stable. And for those, we will make the phone calls to do the intervention, the follow-up. Only home visits are only made for people who are at high risk again. Like, for instance, an elder abuse case, or a case where very high caregiver stress, or that the older person has multiple medical conditions and very unstable medical conditions. Those will be the clients that our care managers continue to visit. For our medical home care, which take care of people who are homebound, elders who are homebound and at their end of life, it basically remain open. But similarly, the principle is no visits for maintenance, stable cases, clients, and only phone calls, and make the home visits if necessary when, for high-risk clients. So that is also the same for our medical home care. Can I have the next slide, please? Just 5 more minutes I have, so I must go quickly. So I think I won't go through. So you can see, basically, like I said, during DORSCON, this is what happens, but our training programs completely stopped, okay? Yeah, so can I go to the next slide? So the next slide is, next slide is then we had the circuit breaker. The circuit breaker is one level, it's not red yet, but it's one level more severe than orange. And for that purpose, for the circuit breaker, we were all told to work from home except for essential services. And the essential services are identified by the Ministry of Health, by the government, by the Ministry of Health, by the Ministry of Social Affairs, who are the services that are considered essential. But everybody else work from home. So within our cluster of services, we had two considered essential services, and that's our primary care clinics, it's considered an essential service, and also our medical home care, who takes care of people at home. For the rest of the other services, the day centers, the community care management services, the counseling services, they're all not considered essential as such. But again, the care managers are able to visit clients who are at high risk. And for our daycare, they cannot come into our center, but we continue to visit them at home. And if for elders who must go to a center because the family situation is so bad that they cannot just be at home, the MOH, our Ministry of Health, has designated different day centers. I think there's a small number of day centers that are designated to open, and these frail elders can be referred. These elders can be referred to those day centers during this circuit breaker period. Can we have the next slide? So the same community participation programs completely stopped. Of course, training completely stopped. And so this was what we had during when we had the Can I have the next slide when we have this is the dots from orange. Okay, so what does it mean? Okay, these are the insights from our team. That means this is really the impact on our own people, our professionals, our care workers who delivers the services. One is Zoom fatigue. I think this one probably everybody can relate to, you know, that you spend the entire day really looking at the screen, talking to people online, maybe sometimes not seeing them. And it can get very tired at the end of the day. And you do that on a daily basis. And also the other thing we found, our teams have found, is that because of the current situation, because we are not able to meet one another and to work together, we tend to meet more. You know, I have teams who tells me that we do huddles every day now. Our care management teams, for instance, they do a huddle every day because they need to keep in touch. They need to know what is happening, you know, what all their clients, what all the clients are like, are happening to them. And, you know, so they need to hear from all the different team members. So they do a huddle every day, and it's done through Zoom, obviously. So that one of the things that comes up is really this Zoom fatigue. The other one that is really interesting is this idea of I need my team. I think this whole situation, because we had to work a lot from home, we had to use a lot more digital platform, you know, we realized that, hey, actually the teamwork is very important. That, you know, there are things that I can't do, but my colleagues perhaps can do, you know, and I need her to give me the information. It becomes more urgent. It becomes more, I think people see the relevance of it more, you know, in terms of working together as a team. And that's also part of the reason then why there are more team meetings. The other impact that we are seeing is that this thing called we need each other is not, it's really got to do with the community, because, you know, in a community of care services, there are many different services in the community, and any older person will need more than one care services. So during this period, our colleagues also find that they need to really start talking more to the other service providers out there. Like, for instance, you know, our care managers go in and see that, okay, this older person, the skin condition is breaking down, you know, and so she knows that she will need to work with a nurse, a visiting nurse, a home visiting nurse, and we have a service like that, and to come in and take care of the wound. And so there is a lot more communication, there's a lot more meeting together, even for case conferences, to really see what we can all do, you know, to better manage the clients whom we are serving right now. So this sense of, hey, you know, I just don't need my team, but I also need the other people out there, the other service providers out there, and we really need to work together much more. I think these are insights that our teams are getting. And of course, the other one is the wonders of machines, you know, as in they also begin to realize that some things actually we can do, like for instance, you know, our counselors have always felt that if you want to counsel, you must do face-to-face. Otherwise, you know, it doesn't, it's not effective. I think with this situation, they have no choice, right? They have to start using the phone a lot more. And I think they're beginning to find, for example, that, hey, actually, you know, it's not that bad. You know, we can actually do quite a lot of things on the phone, through the phone. Same with our other team members. So I think the insight that, you know, the use of machine can actually help us. You know, it's more open to this idea of using machines to, you know, for the communication, you know, for making contacts. I think this is another insight that's coming up. The other one is work-life balance, that because you are online all the time, it doesn't matter what time of the day it is sometimes. So and also because we are in a kind of a lockdown situation, I mean, your kids are at home, your spouse is at home, everybody is at home, right, with you. And so the work-life balance becomes really quite a challenge, right? So this is really the impact from the team on the ground. Can I just have the next slide? Okay, this is done by the Social Service Research Network that is based in the National University of Singapore. This is actually a snapshot, right? As you can see, the data was collected over a week, and also, you know, the who are the people who contributed to the data. But it gives you a sense, you know, of what are the presenting issues, what are the issues you're beginning to see on the ground. Of course, this data does not cover just older people, right? It is across the board. So it is families, older people, younger people, but it gives I thought I shared this because I think it gives a good sense of what are some of the issues that we are beginning to see on the ground? What are some of the impact we're beginning to see on the ground? Because the data shown in this is very close, very aligned to what we are seeing on the ground ourselves. So can I have the next slide? Okay, these are the next slide. This is really the impact on our elders. Okay, so as you can see, there's a lot of boredom. There's a lot of boredom because they can't get out, they can't meet their friends, they can't come together, particularly for elders who are into community participation programs. There's a lot of disconnection as well because they can't come out, they can't go to the services that they are familiar with. They are very much on their own, especially if they live by themselves, and then what we are also seeing is deconditioning happening. We've seen people who are the frail elders, especially because their buffer is so thin that, for them, the mobility become weaker, for example. Deconditioning happens because they sit a lot more on the chair, they don't move around so much, right? The skin condition, for example, it becomes more fragile. The skins break down more easily, again, because they are sitting so much, we're also seeing some situation where there's a little bit more hospitalization and nursing home placement, that people become, like I said, due to deconditioning, there is, impact the medical conditions, the functioning of the person. So, this is just what we are seeing on the ground. So it is not collected data, so to speak, but it's very much based on sharing antidotes, what our team are sharing. But these are some of the things we are seeing: stress and fatigue from the caregivers, especially, also the helpers in the family. There's a sense of stress, fatigue. And the other thing that we are seeing is that if the family already is in conflict, for example, the conflict tends to be enhanced. And if there's a situation of abuse in the family, that abuse also seems to be enhanced. Yeah, because I think you're kind of packed together in this, in lockdown kind of situation. Yeah. So can I have the next slide?
Sorry, Kim Chi, I think we have to wrap up really quickly.
Yeah. So this is
summarize.
Just one last slide, because I think this is, to me, this is really what we're getting out of it, in the sense that, like I said just now, the more important, they need to work as a team and not in silo. I think this situation really brings home that point. The creative use of technology, and really the urgent need to educate our elders and caregivers how to use it, because we are saying that we tried, but they can't use it. So it's very frustrating for both sides, right? So this is really important. And also reinforcing the idea of community as care volunteers, that how do we utilize the entire community, especially in a situation like this, to become that care volunteers, to contribute to the care of a very vulnerable group of people. And I think last but not least, but really redesigning a more efficient work process. There are a lot of our work process can be redesigned, so that it's more efficient, perhaps a lot more based on digitalization, for example. So these are just insights that we're getting, it's still evolving, I think, but certainly for us at the foundation, these are some of the areas that we need to think through very deeply and need to look at how, from insights, how do we move into really better understanding, creating a plan, a different process to support the work that we are doing. I think that's I think that's all I have, right? No more slides, right? Okay. Can I see what is the last slide? Okay, this one you can get from the website anyway. Come 1st of June is safe reopening, but there's phase 1, phase 2, and phase 3. And phase 1 is fairly similar to COVID, to the lockdown situation, actually, to the circuit breaker situation. We are still going to work split team, only essential service functioning, the other services mainly about the same. I think the entire nation is really watching to see how it goes for the next 1 month, from in June, before we really move into a phase 2 and phase 3.
Everybody, good afternoon, ladies and gentlemen. I would like to also say hi to the panelists. We've been communicating through emails. I'm glad that this afternoon we meet in this event. So my presentation will cover some topics. The first one is the current condition of elderly in Indonesia, and then our proposal of integrated elderly care, the design, as well as Silani. I'll explain later what is Silani. And the last coverage will be how Silani will support the new normal in elderly care in Indonesia. So this is the current condition of older people in Indonesia. We are very fastly approaching aging population. We have 26 million, as Pak Hunggi in the beginning of the program said to us, that are age 60 plus, and the number will increase to about 43 million in 2030, mostly women and at higher risk of poverty. On the other hand, we also have problem with the economic security of this elderly. Only 10.5% elderly currently receiving pension. 25% of those elderly are currently receiving some sort of social assistance, including the conditional cash transfer, as well as food voucher, or as known as program SURGAKU. There are care and services available for the elderly, but only for a few people. Currently, based on the Ministry of Social Affairs data, about 200,000 older people receiving care. So what are actually the urgent needs? The first one is service improvement. Most elderly care now is provided by family, so we need to find a way how to expand more elderly care, as well as improving the capacity and the quality of the programs. We do need to think about expanding economic security. Access to social security such as pension needs to be enlarged, and especially for the younger population that will be the future elderly. We also need to think about well-targeted individual and family-based social assistance to cover and provide protection to the vulnerable elderly. Data is an urgent need. We currently have data, but only focusing on the socioeconomic status. For elderly, we do need more information. We do need their health status. We do need to know their needs and their social challenges for us to be able to provide sufficient care for the elderly. And we do think that the data need to be universal, so not only focusing on the poor elderly, for example, but all of the elderly to understand exactly what are the needs of this population. Emergency responses is also an important thing. We need social assistance to expand quickly during emergency, covering the vulnerable population, including the elderly. And we also need to create an adjustment, as explained by previous panelists, of care and services during the emergency situation like now. So this would be the proposal, the proposed design of the integrated elderly care. We have the elderly on the left-hand side, and on the right-hand side is the whole integrated elderly care system. We do have all of this care now. We have healthcare, primary healthcare, and secondary healthcare. We have social care. We have community-based programs like home care, daycare. We have other institutional care as well, such as residential homes, but they are not well integrated yet. So we want this to be more integrated in terms of providing services to the elderly. And we want to have also the very key factor of this system is the care hub or the case manager. So with the existence of this institution, elderly will be able to contact the care hub or the case manager, and then they will be able to diagnose what's the needs of the elderly and what kind of care or services that the elderly can get. That would also cover subsidized care or a care that paid by the government, or even if the elderly is able to cover some of the expenses by themselves. This type of integrated elderly care cannot run without being supported by good database. So that's why I mentioned in the beginning, we do need a data, and Silani is one of our pilot in Bapenas that was conducted to collect data of elderly in several places in Indonesia. So Silani is a short for Sistem Informasi Lansia, which is in English is Elderly Information System. So Silani covers many information of the elderly, the demographic information, for example, location and contact, health condition, disability, mental health, dementia, as well as indicators to inform us whether or not the elderly need caregivers, the elderly socioeconomic status, the availability of the caregiver, whether or not they have caregiver now, as well as access to facilities. So we are thinking that this type of data is necessary to help us defining what are the needs of the elderly, and in a more micro level, what are the needs of the elderly in a certain region. This data will help the care manager or the care hub, the case manager, to provide good diagnostic, to provide appropriate suggestion to the elderly what kind of elderly care they should get. And we also hope that this data will be linked to a much bigger data in Indonesia. It's called DTKS, which is the Unified Database System for Poor Population. So in case the elderly are vulnerable or poor, they will be able to receive some social assistance program as well. So these are some selected results from the Silani pilot. I told you in the beginning that Silani is one of our pilot of the elderly information system. For now, we are piloting this system in 7 villages in Jakarta, Jogja, and Bali, covering about 14,000 elderly. The participation rate is pretty high. Only about 2% of the elderly that we approach for this data collection refuse to participate in the program. Excuse me. Some of the result of the database that we have, this is some of the new information that we never had in this level before, is that about 10% of the elderly that we collected data from, they need caregivers to conduct their daily activities. So these are the vulnerable elderly that we will probably need to provide some type of programs or protection. About 43% of the elderly have disability, 17% have mental health problems, and 35% are facing dementia. In terms of socioeconomic, some of the elderly are still very healthy, and 30% of these healthy elderly, they are still actively working. Those who need caregivers, those who are no longer active and less healthy, they financially mostly depend on the family member or government assistance. And surprisingly, 24% of them do not have any income source, any stable income source, even government assistance or income from the family member, which is quite concerning. In terms of caregiver, those who need caregivers are mostly female, and their age is mostly above 70. About 79% of the caregivers are family, and about 12% of the elderly who need caregivers, they don't have it currently. So this is also the potential clients for the government to cover, to provide protection. Most of the elderly say that they need caregiver and healthcare. However, the healthier elderly, they said that they need more social activities, including health activities, religious activities, even economic activities. They still want to be active in the labor market. So we think that the pilot that we have conducted in 7 villages in Indonesia are is quite successful, and we think these are some of the factors contributing to those success. The team built the data collection method using community-based method. They are approaching people that have lived in the villages for so long, have been working with the elderly for so long, and the team is also was also trying to institutionalize the skills, meaning that we want the skills to stay in the community or even in the organizations within the village. We try to train them, and we ask them to train these other people as well. There were some communication in the ministerial level that helps, especially since many programs are conducted by different ministries. In the local level, there are both vertical and horizontal coordination. For example, in the village level, people are coordinating, service provider coordinating, as well as with the higher level of government, and of course, political commitment of the region is also a center point of this success. So these are the plan for the integrated elderly care pilot. So the pilot of the Silani is just the first step. The next step is to actually create the integrated elderly care. And we start with the Silani because we think that data is important. So these are some of the steps that we are thinking. First, we need to integrate all of the programs. We have a lot of programs that are conducted by different ministries, so we need to create linkage, put them in the same page, and put them into a more coordinated arrangement. We need the function of case management. Currently, probably there have been some type of this institution in the village, and maybe there are also some uninstitutionalized skill of case management in the local level as well. We need to make it more organized, especially toward elderly community. The programs don't also need to be integrated, but they also need to be developed as well. The quality of the program, the coverage of the program needs to be bigger as well. The fourth one is the Silani utilization. The data that we have collected need to be the base of our intervention. Our intervention needs to refer to what Silani told us, and we are thinking of developing a Silani digital platform for that. And the last, which is in many chances is the most difficult, is financing mechanism. Developing sustainable financing mechanism will be the next challenge. We are trying to do that now. Whether it's contribution based or tax based, that's going to be, but there will be something that has to be established to fund this innovation. So this is the Silani digital platform that I was talking about. This is just a mock-up, so this is not the final the final display. But we're thinking to have this. We are thinking of having Silani digital platform that is connecting many stakeholders in the environment to support elderly. So this is a more detailed explanation of the initiative. The Silani digital platform in the middle is connecting elderly, their family, the community of the elderly, including other elderly. It's also connecting government, the case manager, of course, facilities and services. So we are thinking that Silani digital platform would contribute to the new normal in the elderly care, because the base of the digital platform is online. This probably will help to reduce the physical interaction that needed by the elderly to get some care. So for example, because this facilitates connection with other community members, peer groups, and other elderly, the elderly hopefully will not be too isolated and will still be able to communicate with their peer groups. And since the family members and the caregivers will be able to connect to the elderly through this platform, it will be easier for them as well. If the elderly needs something urgent, they will be able to be the first responders that help elderly. We also hope that elderly will be able to self-register themselves or being helped by the family to register to the system. And once they need something from the government or from the community, they will be able to use the system. The care hub or the case manager will be able to see what's the needs of the elderly and probably do some remote diagnostic and link them directly to the care that they need. The government using this platform will be able to provide information about social assistance or other programs that are conducted regarding emergency responses, like now in the COVID-19, or provide even relevant information about maintaining health or new regulation regarding lockdown or guidance and etc. And then the last, we hope that the facilities will be also actively involved in the platform, providing information about what kind of services they have and whether or not those services are available, whether or not it's safe to access this kind of services. And we also hope that probably some services can also be done from distance. This is still a dream, but telemedicine is now something that is getting more and more possible. So this platform should be able to facilitate that, or even facilities can also provide tips, information for family members, for the elderly themselves, for the community on what should be done during this situation, how to maintain mental health, how to maintain physical health, and so on. So what we are thinking is that we are trying to pilot this. The Silani pilot has been done, and then we try to move on to creating the platform and then creating the integrated program as well. And hopefully this can be something that would help in this type of emergency, and especially if Dr. Rahimah told us earlier that probably this will take a little bit longer than we expected, then hopefully this system can help. I think that would be all from me. Ibu Sylvin, thank you so much.
Ibu Sylvin, and thank you very much for Bapenas for hosting this webinar, and thank you for sharing with us friends from Malaysia, Singapore, Japan, and also the proposal from the Indonesian government. So I want to share some experience during this pandemic. For Indonesia, our first confirmed case on the 2nd of March, and up to now we already have more than 23,000 confirmed cases. And these infections already happen in more than 490 districts and cities. So almost all region in Indonesia already infected by this COVID-19. And the total cases, more than 23,000, and the elderly is about 13% of these confirmed cases. And the data from in the 24th of May, that the death cases in the elderly about the number about 570, and this about 41% of the number of the death cases. So the elderly become our attention, that they have vulnerable, and also they have the high risk comorbid. In Indonesia, about 80% of the elderly still living with the family. This is one of the strengths that we want to keep, and also we want to strengthen the role of the family during this pandemic. So during this pandemic, we strengthen our information to the province and the district health office, since all the activities run by the local government. Next slide, please. And we disseminate all the new information, how to support the elderly living in this situation. So we produce information and we distribute to all provinces and districts digitally, that they need to strengthen, support the family, then they can support the elderly living with in the family. So we educate about the COVID-19 and its prevention, and we ask the family to accompany the elderly to do the physical activities, and we educate the family how to be a good listener for the elderly, to tell the positive things and so on, and also to teach the elderly to use the more digital communication, so use the handphone and so on. This is one of the problem, because usually the elderly in Indonesia, we have problem on using this technology. And the other thing that we also modify our services to the elderly. This is our big challenge, since we introduce the health post, the posyandu, we call it the posyandu, the integrated health post for the elderly, as a facility to conduct the services, and also to have contact with the elderly, not in the health facility. Next slide, please. Now we have more than 100,000 elderly posyandu, but since the pandemic situation, so we recommend to all district health office, to provincial health office, that we need to postpone these services to the elderly. So we ask them to give more information indirectly through the health cadre, to do the home visit and so on. But this become a big challenge for us, since the number of elderly is quite big in our catchment area at the health center level. The primary care level facility, the puskesmas, still remain open, but we ask them to do the modification of services. Even now, we already have the program to have different queue for the elderly, different clinics and so on, but we ask the health center to modify their services to have more ventilation area to do the services. Even we ask them, if possible, we recommend them to do like outside the building of the health center, because in our health center level usually is quite crowded, the services, and this is become make the higher risk for the elderly. And we also teach the health center staff to provide the like telemedicine, to give more information using the information using the digital, and ask them to if they need urgent services, we ask them to have the visitor registration online system. So this is modification of services we introduce for the elderly during this pandemic. For the home care during the pandemic period, we also give some recommendation that they need to apply the health protocol, like to restrict the visitors and also to provide like the isolation room if the elderly have a health problem, and to contact directly to the health services if they need more attention. And to respond to the Bappenas proposal, we really support to have this kind of integrated services for the elderly, since to support this elderly not only to provide the health services but also to provide the social support for them. So we need to discuss more intensively with the other sectors in the government and also with the local government, since the local government, they have the responsibility to provide basic services to the elderly. And in our system, decentralization system, the government at the district level, they have the authority to do to provide the services for the elderly. I think this is the situation in Indonesia. In our big challenge that we need to encourage the community to comply to the health protocol, that they need to have the healthy life behavior at the home during the transportation to the work, but also after that, and to keep the family protected from the risk of the pandemic, the COVID-19. And we also introduced the telemedicine to provide more information and also can give more attention on the physiological issues. But the problem that we do not have the system, the scheme, how this telemedicine also can supported by the health insurance. So this situation need to be overcome, and we plan to develop more program. And if the integrated services for the elderly will be broader implemented in the area, it will be benefit for the elderly. Thank you.
Thanks to Bappenas for inviting me in this webinar, and allow me to share with you about my views or my experience based on my empirical evidence in the field. I try to simplify all the problems of elderly facing the new COVID-19. As you can see, there is a simple graph or simple diagram that I show you this moment. You can see the first circle, the elderly, ADL, and the capability, and so on. And then we call it like the cause effect diagram. So let me brief you what I mean in this graph. Objectively, elderly has a different characteristic between one and another. Therefore, elderly needs to be differentiated by their base living capacity, namely independent elderly or activity daily living, ADL, and elderly who needs help from others as a companion or facilities tools for their daily life or instrument activity daily living, IDL. From these situations, we have to know exactly for each group, we have to know about the capability, the health status, their income, and the environment. These categories is the initial stage that needs to be done directly and to be done correctly also, because it will affect towards the intervention efforts for elderly. If this categorization is not done properly and correctly, it is certain that the intervention given for elderly will not be in accordance with the target, which makes improvement for elderly welfare is from the expected results. So let's move on. Capability, health status, income, environment. Two elderly categorizations mentioned earlier basically needs to consider four main domains for elderly, still in the context of COVID-19. The first one, capability to include employment of older people and educational status of older people. We have to know about this for these two groups. And the second one, the health status that includes life expectancy at 60, healthy life expectancy at 60, and psychological well-being and today's context conditions. Elderly are very vulnerable regarding to their health quality in connection with comorbidity. As you know, that the comorbidity is very clear, it's affected to the infections of COVID-19. Heart disease, high blood pressure, diabetes, and lung disease. And the third one is income security, which includes pension income coverage, poverty rate in old age, relative welfare of older people, and income per capita. So again, both elderly ADL or IDL, we should know exactly what their conditions according to these domains. And let's move on to the physical distancing and social distancing. If we are talking about the elderly, ADL or IDL, on the context of new normal, we have to know exactly of the elderly categorization based on ADL and ADL, as well as for them, it is the exact way to do it in order to facilitate the contents policies formulation in accordance with evidence-based policy principles. Now, after we know exactly about the physical distancing and social distancing, the impact of COVID-19 forced everyone to enter the new normal lifestyle. Maybe for my views, it's not exactly the new normal lifestyle. Maybe just go back to normal style. Behavior changes is important to carry out normal activities while adding implementation of health protocols to prevent COVID-19 transmissions. One of the health protocols is to do social distancing by reducing physical contact with others. Do you think that it is possible for elderly to do this? We can see a discussion. Objectively, the new normal implementation needs to consider the characteristic of those who will be targeted in terms of certain groups that different from other groups. This also applies for elderly. Why elderly? For Indonesia, it is the fact that elderly are a vulnerable group and has a high risk of experiencing a very significant impact in the context of COVID-19 pandemic. In a broad scope, there are 4 consequences experienced by elderly, namely, I think this is from my observation right now, that one is an increase on social exclusion and isolation, which leads to depression, fears, and helpless feeling. The second one is a possibility of reduced limit family. You can see, in normal conditions, most of the elderly get supported from their family. But right now, there's a lot of people lay off from their works. So they will reduce to send additional income for the elderly. The third, still the first slide. The third one, only a small proportion of elderly enjoy the pension. Or more than 80% still have no access to minimum income support. And the last, 4, limited mobility as a result of staying at home activities. Now, if I want to relate it with Mr. Andre presentations, Ms. Kim Cho and Ibu Rahma presentations, let me make explanations. The impact is felt even more when elderly is faced with rules regarding with large social, with large-scale social distancing, PSBB Indonesia, that prioritize the importance of distancing and social distancing implementations, which has been an effect for about 3 months since March 2020. Even for the ADL elderly groups, the impact is still felt by them considering their psychological conditions that they are getting through, which makes this condition is much more harder for the ADL elderly groups. Now, in this regard, actually, I do have my own questions regarding Dr. Andre's presentations, because you you may see as 3 sets: close space, crowd places, and close contact setting. But is it possible to apply for, let's say, elderly, particularly in Indonesia? Living with dependence on aid or assistance from others is very much needed. I think we cannot avoid it. Living with dependence on aid or assistance from others is very needed. Just quote. In the current pandemic situation, hospital should allow close family companions. We cannot ignore them. This is a big issue for elderly because most of them often experience mental health and behavior problems, such as dementia. Elderly who suffer from dementia are exposed by COVID-19 will not only have difficulty for understanding and do precautions acts. They will also have difficulties in explaining or expressing their sickness, complaints, and who they feel because of their dementia. It is uncommon that economic burden is also felt by other family members who needs to take care for the elderly parents. It is necessary to have information about how much economic burden expense needed, given by both government and family for health care during COVID-19 pandemic. This information is needed to support the social protection in the form of social assistance, non-contributory, and social insurance contributory schemes, also national health insurance that needs to be addressed immediately. And actually, I want to learn more from Dr. Rahma about the social assistance and social insurance assistance in Malaysia also. So the last things, another thing that need attention is the education for healthcare workers in dealing with elderly patients, especially those who are suffering from dementia, and also personal protective equipment using can make elderly more stressful and inconvenience. The most basic thing is to depend on the government's ability on how to communicate with the public. Next slide, please. I just have 2 slides. I just to share with you my view for 4 priority. The first one, the inclusion of aging of the need of older person in national development policies and programs. Thank goodness, in Indonesia right now, we do have a national medium-term development plan based on the Peraturan Presiden or Presiden Decree number 18, the year 2020. But this is not enough. The other homework for us right now is how actually for each ministry can interpret or to elaborate more from the National Medium-Term Development Plan. For instance, right now, the Ministry of Health, they are developing a National Action Plan for elderly. So what we need right now is the National Plan of Elderly for each ministries to be implemented or to be elaborated from RPJMN or National Medium-Term Development Plan. About 2 hours ago, actually, we do have a webinar with the Minister, Coordinating Minister for Human and Cultural Development. He also mentions that we have to interpret what kind of the data, what we need for interpretation of this RPJMN. What we need is who actually gives the services, who will receive these services. Now we have to be more careful about this setting the target. I think it's very related with Dinar mentions. I will support. We have to be careful how to interpret the National Medium-Term Development Plan in technical manner. The other thing that I want to share with you is very important is mainstreaming aging into both policy and programs, particularly for provincial, regions, and district. Even we do have in central government, we do have the law, let's say the Peraturan Presiden or Presidential Decree, but in the provincial, regions, and district, I think it's very difficult to set up the new regulations. But right now, thank goodness, there is a success story. Even during the pandemic situations, the provincial, the West Java provincial government has set up the new governance regulation regarding this older person welfare. The other thing that I want to share with you is very important is support communities and families that A family has a distinctive place in Indonesia right now, hopefully forever. It is the most basic social unit with much more country social and economic life revolving around it. So support communities and families to develop support system which ensure that frail person receive the long-term care. I think in line with Pak Dinar mentioned before, they need and promote active and healthy aging at local level to facilitate aging in the place. And at last, strengthening of intergenerational relationship is very important. And the last but not least is the legal identity for a person is cornerstone for social welfare. Laws that are vital to older person are often unclear, contradictory, outdated, and discriminatory in their impacts is a very crucial issues in Indonesia. This is the right time to support or to set up the new legal system for older person, particularly in extraordinary situations like in the pandemic COVID-19. I think that's all from me, and thank you very much for your attention.